Good morning. So it's 8:31. I think we'll get going. So it's truly my pleasure to introduce Dr. Joshua Safer as today's Grand Round speaker. He is the Executive Director of the Center for Transgender Medicine and Surgery and the Mount Sinai Health System. And we were very lucky that he chose to come here last year after previously serving as the founding medical director of the Transgender Medicine and Surgery Center at Boston Medical Center and Boston University School of Medicine in Boston. Dr. Safer has been instrumental in changing the landscape of transgender care. His research helping to show the safety of transgender hormones and to show the health and quality of life benefits that increase access to care for transgender patients. He is the president of the United States Professional Association of Transgender Health, otherwise known as USPAP. And he's also the steering committee co-chair of the International Transgender Research Consortium, Transnet. He also serves as the Global Education Initiative Committee for the World Professional Association of Transgender Health, otherwise known as WPAP, and on the Standards of Care Revision Committee for WPAP. He has authored or co-authored over 70 papers published in peer-reviewed journals, and he's co-author of the Endocrine Society Guidelines for medical care of transgender patients in fall 2017. I could go on and on about all the various committees and task force and working groups that he's been a part of and currently a part of for transgender care and endocrinology as a whole, including the International Olympic Committee or the IOC, which is really not a surprise if we've witnessed firsthand at Mount Sinai his enthusiasm and collegiality since coming here. And since you did not come here this morning to hear me speak, without further ado, Dr. Joshua Safer speaking on state-of-the-art transgender hormone care.
Good. So thank you. That was just a lovely introduction. Thank you very much. It's really very exciting to be here. You've seen me sitting in my corner as I slowly develop that, I guess, into my regular seat. And it's very special to be here at Sinai, where there's opportunity to really move this field forward. Just to be aware, the program here is beginning to permeate everywhere within Sinai, and we are far and away the largest such program and a model for how to develop programs in the country already before I got here, and the opportunities to expand are marvelous. We hired our third full-time surgeon, operating now at New York Eye and Ear, which is evolving into the future Sinai Downtown Hospital. We see patients at Union Square, in Chelsea, and depending upon specialties, up here on the main campus. And endocrine fellows know that they're already rotating through as part of their core experience, unique in the country. Surgical residency program, I'm thinking, will start to rotate as part of their core experience. Again, that will be unique in the country. So very, very special to be here. So it's really a pleasure to join all you guys. Thank you for being such wonderful, welcoming folks. So with this, I want to switch a little bit. So my disclosures, very little here. I was on an advisory panel for Histrelin last year, and then it's endocrine, so just about the whole talk is off-label, but you knew that. And then the objectives here, I'm going to talk very briefly about the change in landscape, because I think a lot of us are up to speed on that, and I'm going to actually try to get us, I'm going to spend maybe 10 minutes making sure we're all up to speed on approach, on hormonal approach, and then go into a couple of cases so that we can actually debate the nuances, because I think that's where we as endocrinologists are going to really have our role as being the people who get those nuances, where frankly we can be helpful because most of the rest of the medical world is more conservative than we are. Endocrine Society guidelines from last fall, which probably already require yet further updating, have really two substantive changes that are relevant. So the slide looks kind of busy, but we didn't do a whole heck of a lot. So on the pediatric adolescent side, the big difference was that when Endocrine Society, in its really pioneering guideline out in '09 came out, and other guidelines that are out there, people wondered about when you should feel safe giving sex steroids to kids, and they used kind of a legal decision-making cutoff of 16, which is not a biological cutoff and therefore there are kids who are well-established transgender individuals where there's no need to go so far, so late and beyond where they should be biologically, and perhaps even have them on some puberty blockade situation where you're concerned about their bone. And therefore, what we did, because those of you who've been on these guideline committees know you can't trump expert opinion with expert opinion. You need to have some little data, and we had none. So what we did instead is we made a new rule or a new recommendation, which was further expert opinion, which is just that if you do this, you should do this in a context of a group that knows what it's doing, a multidisciplinary team. And so by using that verbiage, if you do it, we suggest that there might be some people out there doing it. So that was the big substantive thing on the adolescent side. It's just allowing, creating some cover to be a little bit closer to biology, maybe kids who are 14, et cetera, depending on their maturity level. And this too looks like this is the adult side. And it looks like a busy slide, but really all that's on here are a handful of things in yellow. We updated the language, so we say transgender instead of transsexual and things. We tried to be a little more current. Huge. We moved from something called gender dysphoria, which is still out there as the only diagnosis that's trans-associated, which is a mental health diagnosis. And if we're going to think of this as some biologically encoded thing, that is gender identity is some biologically encoded thing, that has the opportunity, therefore, not to be aligned with some of the other biologically encoded parts of your body, which is how the model for how we're thinking of people being transgender right now. Then we're not thinking that as following a mental health rubric. And so the ICD-11 is going to call this gender incongruence, and I don't know if I love that word, but at least it's more medical and more consistent with how we're thinking of things, and it's going to move to the sexual health chapter and out of the mental health chapter. And so we started using that verbiage. We say gender dysphoria because that's the language that everybody has been using these past, number of years. Gender incongruence / over and over again. And then when we change, we won't have to do a new revision just for that. We'll just do one of those delete all kind of things. The other thing we did is we moved in a more confident way to the diagnosis being made by a knowledgeable clinician as opposed to by a mental health provider. And the point being that if you know what you are doing, if you recognize that somebody has a persistent gender identity that is consistent, and you have dealt with these individuals, and there is no mental health concern and there is no medical concern, they are, especially for us who deal with adults are pretty reliably transgender. It's very, very unlikely. For example, in my practice in Boston, I had a panel of about 300 when I had left. I had nobody who said to me, "Oh, I'm not transgender after all." So therefore our confidence level is just increased, and the idea that they have to go seek mental health intervention first kind of goes away from our guidelines. We still suggest that you have a mental health provider involved, because even if we get to the future society where everybody is just welcoming these people appropriately and treating them in an appropriately sophisticated fashion medically, there's still going to be a little bit of stress involved in those decisions, right? It's kind of a shocking decision. Are familiar with people being one way and then they're another way, etc. And I even, among my young people who have successfully taken hormones, back in Boston, I had 4 young people, make suicide attempts like the week after they started on their hormones. And then they were like calling from the mental health ward saying, just horrified and worrying that their hormones would be stopped. But the point is, we didn't really think the hormones caused this to happen. But, like people would just get on Prozac or whatever. If you remember in the days when the SSRIs came out, there was a little bit of that issue where people just felt enough ability to do something and then they acted. And then we referenced with nothing useful about non-binary persons, and we can talk about it a little bit. I think we in the endocrine field actually are better equipped to deal with non-binary in some senses, because we're not so nervous about the hormones. We're not so adamant that people have to be at one pole versus another from an endocrine profile. We're just worried that you don't make yourself hypogonadal pretty much. and fertility preservation, and we just use the word because we got nothing smart to say. But again, to that future happy place where people are treated appropriately, our interventions, medically and then surgically for sure, really can compromise fertility, and that's going to be the big issue because that's a high priority for people, and having that compromise is going to be the thing we're going to deal with. So jumping through the big shift that I was trying to promote in Boston and that we're trying to promote here at Sinai is really a patient-centered medical model, not forcing people to go to mental health providers, but rather suggesting that if you're trans, you think you're trans, you have a kid who's trans, you have a kid where you think your kid is trans, your kid thinks that he or she is trans, whatever the circumstance, you should be able to go to your primary care provider, and your primary care provider will have a certain degree of experience, just like with anything, and then they'll seek out consultants as necessary, and maybe a mental health provider for diagnostics for kids. We did in endocrine society guidelines, I should just point out, for kids, we left the mental health provider in for the diagnosis just because kids articulate themselves in different ways, and we didn't want to necessarily put that on a lone pediatrician. And then importantly, us, there we are sitting on the side, the endocrine specialists, helping guide in terms of what's safe and appropriate and how to get from A to B. So let me just, again, as I say, as part of this just intro so that we're all up to speed on strategy here. The inputs to strategy are really that presentation in adulthood and late adolescence maybe is more the norm than the exception. We don't have a scan, we don't have a test, we think this is biological, but our data that supports this is not really helping us with mechanism for the most part, and therefore we're waiting for people to articulate by self-report. They both have to have the language, and we have to believe their language, and so that's usually pretty later, usually post-puberty. That's the relevant point when we're thinking of what we're doing. Fertility, I mentioned with the guideline piece, is still an ad hoc item, and that also influences some of our choices. And then when we're thinking about strategy otherwise, the cartoon I have says here, "Good Lord Ethel, you can't appear in public like that." But of course, if you can't see which way to believe, you don't know which one is Ethel. And so that's the good news, is as we age, we all begin to look a little alike, and so we're going to be fine. But somewhere along the way, we have this reality, which is the impact of androgen on physical features. If we're talking about people who are looking to be perceived according to their gender identity. And so I just want to highlight, this is a pair of identical twins. We have to educate our non-medical folks to recognize that identical just means really similar. Identical is just a word. They're not really identical. But in any case, identical twins. On our left, the girl is trans. They're both XY. And they're just shy of their 15th birthday, and all you're seeing here is GnRH agonists on her used for puberty blockade. And just accentuating that a female puberty is more of a linear thing, and whereas a male puberty for boys or men or for anybody who gets a lot of androgen at some point, there's a little more of an inflection point at some juncture where characteristics can be added. And so, and you recognize most of these. You see the hair above the lip that you were anticipating. You know to look for midline structures. The nose is even already a little bigger in the picture. This is, I don't know, a year of androgen. As I say, they're like 14 years old. The squaring of the mandible already is visible. Look at the trachea and the midline soft tissues. His voice is certainly has decreased. Look at the SCM muscles, and this is a known pair where he's not a bodybuilder. This is a 14-year-old kid who's a bit of a bookworm when the picture gets taken. That's androgen. As well the forehead, but that's covered because of the style of 2011, so that those data are lost. But again, very, very dramatic physical features. And then the other thing, and I put this out kind of simplistically because I just want to really accentuate the point, is that estrogen levels between men and women, I'm not sure that they're so clinically relevantly different. That is, if we look at our laboratory, we know that it's statistically different, the female range among, if estradiol is even the correct estrogen to be measuring for estrogen levels, but that's what we measure, and we see it's a little bit higher in women. And when we look at transgender men, that is female to male, and I'll step aside here. Notice that I did not have a slide on language. We just dealt with it, and I trusted you guys to follow and to be up to speed. But transgender men, female to male, when we gave them androgen, we observed that their estradiol levels, using that as evidence of ovarian endogenous production, were in the usual female range. And then after we gave them their doses of androgen, to presumably mostly suppress their central axis, and so what we were mostly seeing was estradiol that was from the exogenous androgen conversion. Those levels were more in the male range, and it was statistically significantly a little bit lower. But again, I can't say that that's a big clinical difference. By contrast, testosterone levels, we're talking about a tenfold difference. And so we think that's where all, or at least the overwhelming majority of the money lies. And so the current approach is GnRH agonist at Tanner2, and for those of us who aren't kids, 2 is when puberty begins, 1, nothing happened. And then there's no need to do any treatment before that, no medical intervention, that is. And frankly, one further aside on that, which is, if we think that gender identity is something that is biologically hardwired, at least to a substantial degree, then if you have kids under the, Tanner 1, so prepubescent kids, where they simply want to change their clothes or their hair and do what is called a social transition, you can have some confidence that that would be okay, because that's 100% reversible, right? You can change your clothes, you can grow your hair differently. And the idea that you'll brainwash those kids seems unlikely, because if we would have been able to brainwash them, we would have been able to brainwash the intersex kids who we failed to brainwash, who are probably our biggest evidence that gender identity has something hardwired in there. GnRH agonist, like I say, at Tanner2, and we have some comfort with this for precocious puberty, and we follow very similar regimens. And then with the guys, really we're just doing androgen supplementation. And I'm pretty agnostic, and we can talk about it if we get to it, but we probably won't, because you guys will probably interact too much, and so it won't happen. But I'm certainly happy to discuss it as needed. I'm pretty agnostic as to how you give androgen. Most of these guys read online that they want injections, and I love injections personally, because I don't really worry whether they're absorbing it or not. But gels are fine. Again, our own practice patterns and the patient preference influence things for the most. There aren't data one versus another. And then for women, what we're really doing is we're blocking the androgen. I think that's the key point. It's not estrogen versus androgen, which a lot of people think, but rather androgen up, or testosterone up, testosterone down. And the most convenient agent would be estrogens, estradiol, because they both feed back centrally to help knock down the testosterone, and we don't want to render our patients hypogonadal. And so estrogen then is there. We keep them with good bone protective levels. Problem is, we worry that there's a thrombogenesis element there, and we worry that there's a dose response connection. And therefore, we think that if that's true, that if we could lower that dose a little bit with other androgen-lowering regimens, that we would be a little protected, maybe. Not that we have any data for any of this with transgender women, but we think it. And that's where that spironolactone comes in as part of the cocktail, or other agents. All right, so now that we're all totally up to speed and ready to be endocrine experts, let's just jump into I have a couple of cases, and then I have a spare case if you guys are too tired to talk. All right, 17-year-old with male external anatomy tells you she is a trans woman, sitting there in clinic. She arrived in New York for college, has been living as a boy back home, but never had hormones or surgeries. And as an aside, which will become relevant in just a moment, heard that spironolactone, the adjunct agent that we've been using heavily in the United States to help lower testosterone, may not be preferred, read some nasty things about it online, and wants to consider progesterone or finasteride, which is what's written online as some alternatives on the trans websites. Alrighty, so would you prescribe hormone therapy to this patient? It has to be yes or no. Right? First one's easy.
I want to take more of a history first.
More of a history. What do you want to know?
I want to sort of hear the background. You know, you want to get the full perspective. Patient comes to you, but has been complete, you know, has been male up until this moment and presents now with the transition of college, which can be obviously a very stressful time. And you just want to get more background on this and what's going on. It may have just been the departure from home, parental influence, but you want to just get a little more background.
Yeah, so getting some history and convincing yourself that this is reasonable, and I think that's a fair place to start. And again, if you end up seeing a bunch of people like this and you have more confidence, that's great. If you have less confidence and you want some more mental health involvement or involvement of people who see more of these patients, that's perfectly reasonable. And just making sure that the story kind of fits. And I usually open up with that kind of a conversation. And the overwhelming amount of my patients say, well, at least in retrospect, this has been going on forever, is kind of how they say it, even if they didn't think about it till recently. And in this particular case, it even sounds like this individual's been thinking about it and just was waiting to get away from home. But yes, great. Alrighty, so some other things to observe here are other concerns. So I'll just throw out one thing, which is a little subtle there, but the kid is 17. And endocrine society guidelines would actually say you need a mental health provider for diagnosis below 18, for what it's worth. And only for adults do we say that we're confident in making that diagnosis. So just to be aware. But in any case, she's post-puberty. We're thinking of an adult regimen, however we get to it. My personal practice as an adult endocrinologist is because I just don't know what the nuances are. I will observe from Massachusetts to New York. In Massachusetts, we were very, very rigid about parental involvement before the age of 18. In New York, above the age of 16, we're pretty the state is pretty liberal. But still, I defer to my adolescent colleagues sometimes so I don't go against whatever's current practice might be. For me, if I have the odd 17-year-old, usually they show up with parents. And they're like, and that way I know that everybody is on board, essentially. The other concerns? All right, so we got to our reasoning. Patient wants to know if being androgynous could be an option using only a testosterone-lowering medication.
I'm surprised how often this comes up, that they're non-binary or androgynous, and then when I speak about bone health, they get very scared. Bone health would be a concern.
You said earlier that want to keep some hormones on board, and if you're going to reduce testosterone, would you reduce everything?
Right.
You said reacting.
Right. So point being that we don't want to do that. Exactly. So I think that's kind of conventionally how we think as, part of what we bring to the table right now as endocrinologists in 2019 is we see the people, the men who are hypogonadal and then they present with an osteoporotic fracture, or the women who have either an early menopause or hysterectomy for fibroids, and nobody ever, and there was no hysterectomy involved, and nobody ever followed up with hormone, and then they're way ahead of their FRAX score is terrible. So we see that and we worry about that, and so I think that's one of the things where we can protect our patients a little bit, especially somebody young like this who's going to be exposed to the absence of hormones for decades. And so yes, and that's what I advise my patients as well. I got challenged on that not long ago with what are the actual statistics, and the short answer is don't know. Lots of room for study here, as you'll observe.
Hey, Josh, what about epiphyses? Check to see if epiphyses are still fit, because you can imagine that you might keep growing for a while before you start.
Yeah, that's a great, so just checking like a bone age for whether the epiphyses are fused or not. And I think that's reasonable. I think it's in this particular, when I've got somebody who's age 17, I'm not anticipating it, but I can't say absolutely, especially going through a male puberty. Yep. Yeah, not a.
Well, there can't, if there was.
So yeah, what if it was 13?
still wait. If they want to be male and they're 5'2", they might also want to be taller, right? So maybe that would be an argument to delay.
Yep. So in this particular, yes. So more often we have the opposite circumstance, but for the transgender guys, it's absolutely a reasonable thought. Bad luck for them. Those female puberties are occurring earlier, and so it's less likely that we can be helpful. And in this case, and then we kind of have it the opposite, where more often for the transgender girls, we're racing to get that estrogen in there and lock things in before they grow taller yet. And again, it's all these societal biases around height, and we're trying to help them, facilitate going with the bias in a sense.
How often do you look into growth curves?
With regard to adults,
Yes.
with regard to yeah, so with regard to adults, almost never. Honestly, I'm taking the position that they're pretty much post-pubescent. Adolescent, absolutely right. If you're a pediatrician in general practice, like all you do is measure height. So because so then it's an enormous priority, of course. Yeah. Yes.
Are you concerned about those individuals who may have sickle cell disease or some hematological disorder where they're already have increased risk of thrombosis? Is that something?
Yeah. So actually, that's actually a great question, and and people, I guess where I would go with this is right now the thought process is. What would you do if we give this individual essentially a female hormone profile? Then, what would we do with a cisgender, with a non-transgender girl with a sickle cell trait or disease? We wouldn't be manipulating her hormones in order to protect her. We would be dealing with that separately as a hematological concern. And so that's it. So I think yes, any hematological concern is a valid concern. However, I don't know that I want to treat that concern with hormonal manipulation. I want to do my hormonal manipulation and say, okay, now that's my new normal. Now my hematologist colleague help me with this new circumstance. All right, so the only data, we have very little data, but we have, somebody did one study once, so that's where we are kind of thing. So what all this is using GnRH agonists in transgender young, late teenagers. And essentially, these are Z-scores, because T-scores, of course, would look pretty good. So it's not, and all you're looking at is on the far left, you're looking at baseline. In the middle, it's on GnRH agonist therapy. Not that their bone densities go down, just that they flag behind their peers with their Z-scores. And then on the far right, with some sex steroid on board. And this study is fraught for many reasons. It's a small study. It was done late in teenage years. It was done with low dose of sex steroids, but it was not reassuring because they did not get back to baseline. And so that's what we've got out there, is this bone fear being a real fear, and further accentuating us focusing there in terms of our thought process. And so for these adolescents, discussion of the transgender hormone even at earlier ages. And then a couple of comments here on estrogens. So there's fear of thromboses, and so we don't deny estrogen therapy, but we are a little thoughtful about how we give estrogens in terms of whether that makes things worse or not. So specifically within trans literature, more thrombotic events were seen with ethinyl estradiol a number of decades ago, when that was the main estrogen given by the Dutch group who were pioneering in organizing their thoughts on the subject, and had a cohort of a couple to 3,000 trans patients who were followed for a number of decades. Interestingly, that's the estrogen in birth control pills. So we know that in a different population, we are still giving it out like candy. But there obviously drug companies are working feverishly to come up with a different estrogen, which they will then claim is safer, and then they will be able to charge brand name prices again for. But so far that hasn't happened. But
the risk is due to the estrogenic potency, and ethinyl estradiol is just not much more potent than native estradiol. So it's totally dose related. There's
there's not really evidence in estrogens that it's due to different structures.
Got it. And so, and therefore, by that logic, they're never going to succeed because what the estrogen you need in order to inhibit ovulation is going to give you that degree of risk, or
Right. So that's, lower dose birth control pills work by using progestational agents, which makes a hostile mucus. But in somebody who has no desire for contraception, you only need to give replacement doses. So in other disorders where we replace hormone turners, we create female levels of hormone. And there's vast literature on that. There's vast literature on taking girls with Turner syndrome through puberty and preserving growth. So, there's a lot of data out there, just not in the transgender population.
to use other estrogen.
Well, and to just do it like Mother Nature.
Yeah. Fair enough. So as we say, do it like Mother Nature. I just want to show you that's the other relevant point on this slide, which is the doses up there that I think look high to many people who don't prescribe a lot of estrogens. And here too, I think the literature from surrogate populations is a little bit. So it's funny that Andrea brought up the Turner syndrome treatment, because I think that actually is the bigger guide. Because I think people who treat Turner syndrome actually do use doses that look more like this eventually. Because
Not usually.
Well, what would you say?
Range of 50 micrograms a day.
At an adult level,
Yeah.
so like an estradiol equivalent dose would be
Yeah.
about
And
what?
we use that's estradiol, 50 mics a day.
Okay.
And, we use it transdermally because there's more and more data that is safer in terms of thrombosis.
So let me come back to this. So let me come back to what's on the slide, because these are the oral doses. And actually comparing the two gets to be a little bit fraught, because we don't know well how, we don't have good assays for ascertaining how much is getting absorbed in these different circumstances, and we do have multiple estrogen metabolites depending upon what we're giving. So the main point I wanted to make first, though, was observe that these doses are higher than you might anticipate, and I think it raises the question. And you casually give 6 milligrams estradiol, 8 milligrams, 10 milligrams, and again, we're using testosterone suppression as an endpoint because that's our goal. And so we are maybe going a little super physiological.
Why would you? You need to give huge amounts of estrogen to suppress gonadotropin secretion. So why would you even want to do it that way when you have other ways to do it?
Well, initially, the old history was that everybody thought estrogen was safe. If you go back to the 90s,
Right.
Okay, and so people were very casual. So that's how these regimens got started, with the very high dose estrogens. Now, more recently, the question gets raised by transgender women, as they are like a little resistant to change, as we start to put in some of these adjunct alternatives. Are you really making things safer for me, or is this not that relevant clinically, actually? And I don't have, from a surrogate literature, good data. That is, I don't have a good dose response data at these higher levels in terms of where it's all thrombogenesis risk. And I can't tell them that 10 milligrams is worse than 6 milligrams. Some of us worry about it, but
There are lots of epidemiologic data on estrogen dose and risk of thrombogenesis from oral contraceptives. And there's really no biologic reason to think it's going to be different in the transgender population.
in terms of close dose response, I guess I'm not completely agreeing that it's so clear cut. I guess I would just say that we know it's dose response. So you're taking a very strong dose response position.
I think, that
You're very
would be
convinced.
The kind of position of most of the community, OBGYN.
I'm aware of what people's positions are. Right, there's currently the 50 versus 35.
On epidemiology of thromboembolism with oral contraception receptive estrogen.
No, it's a very good point. It's with using, let's say, the 50 microgram versus the medium pill. So the other thing, coming back to these relatively largish looking doses, is they may or may not be super physiologic. So what has now happened is, let's say we have women who have vaginoplasty or orchiectomy, and so if we talk about the ultimate androgen lowering maneuver, it's a surgical maneuver, and then you're simply adding back estrogen, and you're not using any of these agents to do that. And then if you look at then the question is, how do you ascertain what is sufficient estrogen? Because you've got estradiol assays that are fraught, or you have LH and FSH, which are not the best assays, but it's, let's say, how we get some sense of estrogenization potentially in women who are not menstruating. So if we look at women who have these surgeries and have been gonadectomized, we give them lower dose of estradiol. Some of them have very elevated LHs and FSHs, and they require doses that look more like this in order to have not menopausal LHs and FSHs. I don't want to get I'm not trying to make their LHs and FSHs normal, but I don't know that I want them walking around with 60 or 80.
Why?
I'm using that as a surrogate for sufficient estrogen.
But as you get prolonged estrogen deficiency, the feedback dynamics change at the hypothalamic pituitary axis. So you will never normalize them. And you also have, like inhibins, which if you take their ovaries out, they don't have. So you'll never get.
So I don't.
FSH.
Yeah, I don't know that the data are so good that you will never normalize them. I know that that's the thought process.
With super physiologic amounts of estrogen that put them at risk.
So I know that's the model, and so and everything you're saying to me is exactly, I think, where some of the potential questions actually lie. Like, how much of this is really already answered, and how much of this do we have to our opportunities to investigate with a population where where we actually have that model. And I'm certainly not convinced that it is necessarily the case that we can't that those
So women, non-trans women, cis women, spend a third of their life with high LH and FSH, and there's no data that that's bad for them.
Well, using that as a surrogate for low estrogen, we have a bone health risk, and the question is how big that risk is, but it's something.
Well, then now from the Women's Health Initiative, we do not give estrogen postmenopausally to maintain bone density because we have other agents for bone health in those people who need it, and there's certainly no data to suggest that we need to suppress LH and FSH.
Well, so I'm a little further over on that particular spectrum, because I certainly do use estrogens in postmenopausal women, in part to protect bone if I can. If somebody has symptoms and wants bone protection, I think that's a reasonable thing for that woman to consider, especially younger women.
For the early few years, but then you get into the risks of.
Right. It's again potentially the thrombogenic concerns. It's balancing that.
There's breast cancer.
So it's what are the absolute risks in these regards? And again, exactly this conversation that we're having is exactly the conversation that we have with our transgender women in same experiences, where what are our data, to what degree the surrogate populations reflect, and then also, even if it's true, what's the absolute degree to which it's true, so that what benefit or not are you getting from your estrogens? And we'll get into that a little bit as we go through, because these are some of the huge questions for transgender women, especially when they think they're benefiting.
Once you get to estradiol levels of sometimes 8, 10, split dosing in order to kind of increase the basic estradiol versus metabolites.
So estrogen, so split dosing for higher doses, and the short answer is not especially, and again, that's a lack of, there aren't data to suggest that there's anything there other than the risk that the patient's going to forget one of the, to take her pills. On the other hand, do I care? If she does, it depends. If I'm at some spectrum of hormone profile, I don't know if I'm that worried if she takes her pills or not. But still, that's the only, that's the tension with that one. So here, injectables and transdermals. These are just some doses. And really, where I put these up there for, and this gets into a little bit of the conversation that Andrea and I are already having, which is, so the injectables had been very popular in the 90s and later among transgender women because they got large doses fairly easily. Estrogen could do no harm at the time it was thought. Now we're in this, we've got this kind of circumstance where and then transdermals seem to give us less estrogen. We have a harder time, let's say, suppressing the access with the transdermals just because of the doses that are available to people. So the question then starts to become whether first pass effect is an actual liver-mediated thrombogenic event, which I think many people believe, or is it yet another variation on dose response effect because less product is getting delivered with the transdermals? And hard to say because if you look at those studies, the studies relatively consistently show the transdermals have fewer thrombotic events, but they don't have any reliable measure of how much estrogen is actually being delivered systemically.
Estradiol is very straightforward to measure in the blood. We have very good estradiol assays. And so you can measure, and this is very well documented in lots of clinical research studies looking at dose response effects of estradiol.
But yeah, the alternative reality is it's not all estradiol. So for example, if you do a transdermal estradiol, then it's relatively straightforward.
17-beta hydroxysteroid dehydrogenase converted to estrone, measure estrone too. But you can show very nice dose responses from transdermal estradiol to circulating estradiol.
When you give oral estradiol, by contrast, though, then you're heavily converting it to estrone, which has whatever effects it has, which might be good. I'm only suggesting that it's a little more black boxy than we say.
Still measure the two things.
And speaking of self-interest, I cannot wait to get to testosterone. Sorry.
So just wrapping up this little piece, depending upon where you fall in terms of your sense of what the data are showing you, if you think that this is all a dose response issue, then you're going to be fearful of the injectables where the area under the curve tends to be larger in these women. On the other hand, if you think it's more of a hepatic first pass effect kind of situation, then you're going to like the injectables because they like the transdermals are going to avoid that first pass. So remains to be seen, I think. All right, so the choice of androgen lowering, the choice of agent to lower androgen. Let's walk through that quickly, and I'm just going to go through what's out there. So spironolactone acts, we know, at pharmacologic levels. It's supposed to be a mineralocorticoid receptor, but acts on the androgen receptors also. And then there's a little bit of in vitro data consistent with what we observe clinically, which is that that testosterone levels come down slightly in our transgender women just when we give them spironolactone. And the in vitro data suggests that metabolites of spironolactone can interfere with synthesis of testosterone. And that's heterologous cells. I don't know that I would be totally believing it other than it aligns with some clinical experience. Progestins. This is just a little bit on that topic. Progestins act centrally and lower testosterone in a very clean and neat way. There is one individual who writes literature, a Dr. Pryor, Jerry Pryor from University of British Columbia, who's actually a big bone researcher in the day, took care of transgender people in Vancouver, and she believes that when she adds micronized progestins, that her transgender women have a better areolar development. Nothing objectively documented, but that's out there, and the transgender women read this online. Alternatively, depending on your progestins, you can get some virilization because the receptors on which they act is a little bit heterogeneous. And in the transgender world, we have some data from Europe where instead of spironolactone, they use progestins, cyproterone acetate, as their adjunct agent to their estrogens. That there is a bit of a prolactin bump with the progestin of all things. That is, we talk about fear of progestin of prolactin bumps with our regimens. But here in the United States, in Boston, we didn't see it when we were using an estrogen spironolactone combination. But in Europe, with a progestin estrogen combination, they were actually seeing it. I don't know if that's a bad thing necessarily, by the way, but it's true. And the bottom line is then going to Women's Health Initiative data, we have logic for using progestin to prevent unapproached estrogen, like we all know, on the endometrium. But when we had women who didn't have an endometrium and could take estrogen-only postmenopausal regimens, they actually had less breast cancer and less heart disease than those who took the combination regimens. And so if I'm advising a transgender woman using any of these as surrogates, I don't really have any reason to be giving a progestin. Endocrine Society guidelines, we specifically recommended against use of progestins.
What about doctor development?
And you're saying which way, that you need it?
Yeah, I mean, there's a question.
Yeah, and so, and it depends, and we're a little siloed, and when we go to Endocrine Society, the groups who think about these things think, they think in different, they're in different rooms, and they have kind of what I would characterize as lore, and so that is not really, I don't have any really good data, and we certainly have, you certainly have milk production from individual, men with gynecomastia, and then very strikingly here reported at this hospital last year, a transgender woman. I don't know if I can comment on the relevance of that or whether to what degree that's really true. It's just like out there. 5-alpha reductase inhibitors, we all recognize this for this crowd. That's pretty fast. That's really for people with male level androgens blocking conversion to DHT. If you get the androgen level down to a female level, it's not clear that they're having that useful a role. GnRH agonists, those are kind of attractive to endocrinologists. Why? Because we bring down the central axis in a very clean way and add back what we want to. Really, what's there are their injectables instead of pills, so it's a little harder to administer. There is a little bit of a cost involved. So they're just more expensive. So there's going to be some pushback from the payer, whoever it is. And safety in the short run for fertility and for and for kids who approach puberty over a few years seems reasonably good. But we don't have very long-term data. Yes.
There's a new drug that was approved in the summer. It's an orally acting GnRH antagonist called eligavus.
Yeah.
We've approached that company for some other studies, and it might be a place to go to if you really did want to do some kind of a study.
Yeah, that's interesting.
It's been approved for endometriosis.
Got it. Yeah, it would be interesting. And the only caution again is often these medically treated transgender women are doing this for decades, and so we just, so we're very conservative in terms of what agents we're giving them. And then estrogens we talked about more than some people wanted to hear. So okay, I'm trying to think what to do here. Oh, let me just buzz through this because this is just simply a 55-year-old with male external anatomy, lived as a man a year ago, recent publicity, helped to recognize lifelong incongruence, denied hormone therapy because it's too dangerous. I think we covered a lot of the points for this particular case. The problem with this particular individual is she was quadriplegic due to a motor vehicle accident in the past for which she had a thrombotic event and actually been treated with warfarin. And then we got to go through some of these same conversations in terms of relative thrombosis risk, escalated though, where we have somebody with an underlying concern. And so I just want to use that, and indeed, in Endocrine Society guidelines, this is our table. That's right up at the top. Is this whole thrombosis risk? And I just want to walk through what we know in trans. So this is our best paper so far in trans, which is from Annals from this past summer, which is really just a computer data mining study over using out of Emory, using the Kaiser Permanente database, and where they were able to identify somewhat reliably about 5,000 transgender individuals, and then they used cisgender, about 100,000 individuals in that same database as control. And what they saw were several additional events per 1,000 persons, regardless of whether you were comparing to cisgender men or cisgender women. At about 2 years and even more events over time. So at 8 years, we're talking about 14 to 17 more events. This is simply consistent with we don't know what it's consistent with. Maybe it's due to the estrogens, because that's what we assume is what's changed. With the ability to control for other things, that might be true for transgender women relative to cisgender women, like neglect of healthcare otherwise was difficult to do in this computer data mining experiment. So that is a pitfall. But nonetheless, it's not reassuring. On the other hand, the total number of events is about 150 or so over that whole extended period of time. It's not huge, and mostly DVTs, not strokes or PEs. In terms of actual prospective data, we got about a 1-2 year study with about 700 trans women getting estradiol. This is hugely important because as much as Andrea and I were debating some of the nuance there, the actual absolute event total looks to be pretty tiny, and that's where we endocrine folks are a little bit more comfortable, I think, than some of our colleagues. So they only had one recorded event. So there are no statistics with that at all. And then the older data is just this ethinyl estradiol with about 6 to 8% versus 17 beta estradiol more recently. Andrea arguing that some of that's just estrogenic potency potentially. But the bottom line is that's why we've switched heavily to using estradiol and not ethinyl estradiol. Okay, we have the man gets like only 2 minutes. We have actually 6 minutes left, but by the time we all argue and talk, we'll suck it up. So, 65-year-old transgender man, living as a man for years on a stable testosterone therapy regimen of about 200 milligrams intramuscularly every 2 weeks, has some pruritus, feeling flushed. His crit is 56%. Again, as endocrine folks, we know to even check the crit as being one of the relevant things we want to do. All right, so the treatment-related condition he has experienced, well, let's just jump right to what changes do you recommend? 200 every 2 weeks.
So,
what do you want to know? Yeah.
It's a pretty miserable experience by day 12 or 13 with 5 to 2 weeks. It's also a very standard starting dose, but usually people on that dose are overdosed.
So he seems to be overdosed. Other thoughts, comments on the 200 every 2 week dose?
You would, I put him on 75 every week.
You put him on...
A little bit, decrease some variability.
Yeah. So I think those are actually really the key elements. For some reason, out there in the transgender literature and online and such, people are still using these higher doses every 2 weeks, which have gone away for those of us who do androgens for cisgender men, like decades ago. I'm constantly fighting this, and the Endocrine Society guidelines, we got it switched that both are okay. And again, more expert opinion. The expert in that case is me. And again, trying to take advantage of what we already know, mirroring with the estrogen conversation, what we already know using non-transgender men as a surrogate in terms of guiding our approach. So we stuck in the Endocrine Society guidelines, same table, which is erythrocytosis. and we gave a little guidance that maybe you want to keep the crit below 50%, whether by decreasing periodicity or by decreasing dose. Again, that literature is also pretty vague in terms of what's relevant. There's a lot of talk in textbooks that the periodicity also accentuates your hematocrit, but I don't see a whole heck of a lot of data in that regard. It could be easily area under the curve, and it could be just a straightforward dose response. But in any case, we say keep the crit under 50%. I just want people to be clear on what a data-free zone we're in. We didn't have any trans data, so we looked to the cisgender guidelines from Endocrine Society, and they have 50% written, so we copied that. But the interesting thing is they also have no data, and they actually went to the hematology literature and observed that people have events with polycythemia vera at a cutoff of about 55%, and then they thought in their meeting that, let's, because this is exogenous estrogen, why don't we create a cushion of about 5%? And so they completely made up that 50%, stuck it in the androgen guidelines, which we then copied in the transgender guidelines. So just so you know where that's from, it's not that hard a number, but we're using that as our rubric. And then the other thing to think about here is that, so testosterone stimulates erythropoiesis. We all get that. The athletes all know it too, that they're not all just looking for muscle there. That androgen-stimulated crit that we observe is usually within the normal range, but I wrote polycythemia may be unmasked. Elevated crits in general are more of an unmasking of another concern, and I think that's a relevant thing to put out there. It's not that we cause this with androgen. It's not that men with conventional testosterone levels are per se have these elevated crits with risks, and so it's important to go back and think tobacco, sleep apnea, and if you can't get that dose, if you can't get that crit where you want it to be, it is a hematologic question. You didn't cause that by treating your transgender guy. Just like you don't cause it by treating your cisgender guys. I have hematologists who call me and they're like, can you stop the testosterone because the crit is much better? And I explain that I don't treat their disease by causing my own patient the disease with hypogonadism. They have to stay in their own lane, as it were. But I would say, vis-a-vis the rest of the conversation, it's acceptable to mitigate the high crit with a slightly lower dose if we're in the normal range. I have guys who are a little super physiologic, like Ron pointed out, and so it's totally reasonable to back off a little bit. What you'll observe is that a lot of your transgender men will do chest surgeries, but not genital or gonadal surgeries, and so it'll be important to them to not menstruate. And so that'll be a guiding element here, is they'll want enough androgen on board so they're not menstruating, not so much that they have too much acne, and it's going to be balancing that and the crit probably, and trying to get to a happy place where all of those are addressed. Weekly dosing, and the other thing we get from the trans world that actually I share with my cisgender guys is that they do subcutaneous dosing. And now we've had a handful of series out there suggesting that we can get perfectly reasonable levels. We're customizing the dose to the guy anyway. And so it's perfectly reasonable to do this less painful regimen.
The testosterone product, which is subcutaneous, it's possible because it's an anaphase.
Yep.
And yet they have a curve that looks like a straight line pretty much in terms of testosterone.
What I'll observe, and again, people have not looked at this in a very sophisticated way, but if we just give old-fashioned testosterone enanthate subcutaneously, it's we find that on a weekly basis, we find their peaks and troughs look, at least clinically, very similar to the IM. So there's no real reason to be torturing these guys with IM. The enanthate work creates that long-acting feature. Yeah.
So how is it that everybody's using IM testosterone, whereas in the cisgender world, it's a niche product used by patients?
It's the power of the internet, in my view. So how is it that we've got the cis guys are all doing gels, and the trans guys are all doing injectables. And it's backwards too, right? Because the cis guys are heavily of a certain age and a certain girth, where it would be more convenient if they would just do an injectable and not have to, because they need so much gel. And I've got these tiny little trans guys where, frankly, they could use gel. But they come in, it looks to me just the internet forums and such. If I could, I would convince them all to just do sub-Q testosterone once a week. Then I could easily be confident that they were getting good levels, be less bother. But yeah, it is a question. All right, so I think that's going to be our last case for this morning. I thank you for your attention and your debate. Yes.
So Josh, I mean, it's striking how little data. Right?
Yeah.
And so just fundamental questions. How many trans people are there in New York and in the United States? I mean, what would it take to get populations in the Sinai system? Do you have any sense of that?
Yeah, so when people are surveyed online, about 2/3% of people say they're trans. So that would translate
in the U.S.,
which would translate to about, 1.4 million people. Here in New York, I guess we could just do the math. 1 in 200 people. Then a further survey, of which I'm aware, pretty crude, of just transgender people online, or people who say they're transgender online, about half of them are looking for medical interventions, a half to 2/3. So maybe we're looking at 1 in 300 to 1 in 400 people looking for medical interventions.
male, female? What's the ratio?
The ratios of these online surveys are pretty evenly divided. In the past, we used to see more transgender women because I think it was easier for transgender men to simply not do so much. Society is much more tolerant of women with a more masculine appearance, whereas the moment a guy has a more feminine appearance, he has to kind of say, well, that's because I'm not a guy, I'm a transgender woman, and they're forced to be more out there.
So I mean,
yeah.
So I'm just trying to figure out if you were to do clinical trials.
Yeah.
So then the next part is who funds research and such?
Yeah, so NIH has no home for this right now.
Has what?
Has no home, right. It's actually a big problem. We finally got a PA out January 2018, so it's just about exactly a year out, where just declaring this to be a priority, but no money goes with that PA.
What about private foundations?
What institute was that PA from?
It was for a number of institutes. So I'm kind of hoping minority and health disparities will actually bother to fund. The NICHD has been the one that has funded some of this, but truth is, most of the funding is coming from infectious disease and in mental health and in substance abuse. So that ends up being most of the studies that you see. They're all the associated morbidities from neglect, rather than actual studies of what we want to know, which is the physiology of our interventions. Nothing. No, so yeah. See, these are marvelous thoughts. So here's kind of where my thinking is on this. Transgender women overwhelmingly take a financial hit when people become aware that they're trans, no matter what their circumstance. So when I was in Boston, I had like a Fortune 500 exec who was now somehow got fired as she transitioned and is living off her 401k. And so even though she's pretty affluent, she's not feeling very affluent. And on down, and a cascades on down the line to people who are getting in sex trade because they were in a pretty rough situation, as it were, initially. So what we're thinking here is that people with kids who are transgender are not taking a financial hit necessarily, and among some of them, and it's been the case already. In fact, we have a woman who is a little bit of a spokesman for us as we try to cobble together thinking about how we can get people to support this, who is simply an affluent woman with a transgender kid who said, the kid says I'm trans and I can't find a provider in New York City to help me because it's a wasteland out there. And so that's, if you're thinking about philanthropy, this is kind of where we at Sinai are thinking. So far, my experience has been they don't want to, they're willing to invest a little bit, but they're mostly interested in identifying new donors and not, serving as a parasite on existing donors who are supporting other research priorities.
Are you guys planning any clinical trials?
What we're trying to set up right this moment is just getting our patients registered, just getting our patients into a database. And we have the resources to do that here at Sinai. We got about 2,000 patients down at the Chelsea practice. We have about 800 patients have surgeries here, which is the most anywhere. And I think we're really just beginning, because I think the numbers are larger than that. Cal and Laura, the big LGBT center, has about 4,000 patients, they think, but we could probably bring them into anything if we would set up a structure for investigation. It's kind of where things are at the moment. Yes?
So much. One quick question to clarify for myself and the audience. So talking about bone health, my understanding, some people correct me, is that estrogen is the main driver of bone health in both sexes. So about 70% in males is via aromatization of testosterone to estrogen, the effect on bone. And you don't need a hell of a lot of estrogen to protect your bones. So, like the high dose estrogen, I don't think that's doing anything for bones. Because in postmenopausal women, they've shown that to suppress osteoporosis, you just need very little estrogen. Is that the correct thing?
That's how we're thinking in the trans treatment world.
Yeah.
And so for the younger women, we're using these superphysiologic doses. But as women age, we're certainly looking for opportunities to get their androgens down by other mechanisms. You have to ask the question if you have like a 65-year-old transgender woman on high dose estrogen still, because she's using those estrogens not just for bone health, but to block her testosterone.
The bone health piece of it,
Yeah.
very little.
But maybe she should be considered orchiectomy at that juncture if her testosterone's that low anyway, so that we can follow a more conventional cisgender woman approach with the estrogen piece. Yeah, absolutely. Okay, good. So we're at your appropriate 5 minutes over, so thank you all.